something a mentor said to me years ago has really stuck with me. And it's along the lines of, if we don't do our jobs right with orthopedic care, some clinician will come along and offer a more invasive, a riskier, more aggressive, and a non-reversible approach to the care, treatment intervention. And because that can often be problematic and, like I said, irreversible, we want to avoid that at all costs. Now, that kind of informs how I see my job as a teacher first. I really want patients to understand what's going on so that they're less susceptible to kind of marketing or assertions from other clinicians that can lead to these poor outcomes or poor procedure choice down the road. This mentor was Mark Miller. He and Chad Gray own the clinic IMC in Tallahassee, Florida, where they employ only clinicians who, in addition to other orthopedic principles, use Rob and McKenzie's principles of repeated movement testing and treatment when necessary. So I decided to work there for about 5 months or 6 months a few years ago when I had the time, because I really wanted to be immersed among clinicians who understood this type of testing orthopedically and this type of treatment. Because we do find when we use repeated movement testing that 70 to 80% of people's orthopedic disorders can be reversed with 1 or 2 simple movements. And of course, it can be challenging to find that specific movement. Sometimes we hit a home run on visit 1 or 2 and we see the patient 1, 2, or 3 times, and that brings our averages down. Sometimes we need to spend more visits investigating to find what the perfect movement is for that patient's shoulder complaint, knee complaint, low back complaint, etc. But I decided to work there to absorb information from the other clinicians and my bosses, and I did just that. But him saying that to me was really important, because in orthopedics, there's not great evidence for orthopedic surgery. You can look at the literature when it comes to comparing an orthopedic surgery with a sham surgery, where they maybe anesthetize the patient, do some cutting, make the patient feel like it was surgery, and compare outcomes with the actual tissue change, doing the surgery on the tissue, or just pretending that they are. That evidence is not a resounding yes in favor of actually doing the surgery. There's also a meta-analysis I mentioned, or systematic review I mentioned last year, I think, in a video, where they looked at 10 or 14 common orthopedic surgeries and didn't find much evidence for many of them. There is a time and a place for surgery. I would be happy to be in the US if I were in a car crash and my scapula was shattered, or if I took a horrible fall and I fractured my tibia, or I tore something aggressively in my lower extremity, making walking impossible. I'm glad we have those as resources, but we have to recognize the time and a place where they're indicated. Most orthopedic disorders, which are of course disorders of the musculoskeletal system, which is the system in charge of moving the body, can be fixed with movement. Unfortunately, I think American culture really teaches us to think that science and technology and procedures are where the heart of orthopedics is where the heart of medicine is, and we're so lucky to have it. But that's not the case. Medicine, or healthcare, should be focusing on the things that keep us healthy, and movement is the largest kind of lever in the sphere of orthopedics. But sleep, nutrition, sunlight, other things like that also play a huge role in keeping us healthy and used as strategic treatments to reverse health disorders. When I say that I think orthopedics is especially vulnerable to this paradigm, is because if someone's back is hurting and they go to 3 or 4 different clinicians and it's not getting better, they will consider the surgeon or the person who offers stem cells or the person who offers to take out their blood, spin it around and put it back in them, or any number of other things that are invasive. They will be offered those as treatment options, and they will be seriously considered if not taken, because the person is sick of living with the problem. I know this experience because though I was never close to considering surgery for my low back problem, it was a big deal in my life to have consistent disc herniations, going to clinicians who focus on core strength, on right hip strengthening, on soft tissue release of my right lower back. And knowing what I knew from physical therapy school, I was doing my own kind of general movement and strengthening, and they helped a little bit, but they didn't correct the problem. It continued to happen on a frequent basis, and it pissed me off. It didn't feel great to have this problem. And like I said, I never really got close to considering surgery, but I can imagine if I had a few more episodes where it was life-altering for several months and preventing me from enjoying things I like to enjoy, including exercise, and someone said, oh, we can do surgery. We see a small disc bulge or disc herniation at L4, L5. Yeah, we do these microdiscectomies or fusions or whatever all the time. I probably would have considered it. And I want patients to actually ask clinicians, myself included, surgeons included, show me the evidence for this. However, it's hard for patients to actually read through that evidence because they don't understand how to tell if the methodology is good or even the statistics. in my field, I understand how to read those studies because I could ask the questions, well, why did they consider this? Why did they exclude this person? Why did they include this? Why didn't they test this? Patients can't do that, but they should feel free to ask for the evidence or to go online and obviously look for their own research and evidence. But in orthopedics, those things are regularly offered, and patients in the United States think that because it's more technologically advanced, it's better medical care, it's better healthcare. And in other fields of medicine, I don't think the typical person who has had GI distress for many years and gone to many clinicians without getting it fixed. There aren't many surgeons who will offer to surgically change the colon, right, or the small intestine. And that's the different paradigm in orthopedics. And like I said, there are indications for surgery, but as a clinician, I've seen the people come to me after lumbar surgery with an open, oozing wound where I sent that person to the hospital and he was admitted to the ICU. I've seen a person who had an Achilles rupture. I remember her clearly because she was playing musical chairs at an office party and her Achilles just went pop. I've seen her, I remember her having surgery. It wasn't healing and they were doing grafts from all over her anterior thigh to repair that distal calf, to repair the Achilles area. It became a protracted process for years. And now in retrospect, looking back, I can understand how people just do something very benign and rupture an Achilles. She was overweight, I remember, and she probably, in retrospect, knowing what I know now, quite insulin resistant, maybe other health comorbidities as well, that predispose tendons to failing under such little load. But I've seen the people for whom surgery was successful because the patient selection was on point. That person was the perfect candidate for surgery and therefore the surgery was successful. But I've also seen the people for whom it was not. And like I said, surgeries are irreversible and carry a much higher risk profile than conservative care. So what I want to say is, in closing, is that I do take my job very seriously and I really want people to understand what we're doing so they're less susceptible to claims that a better treatment would be a more invasive treatment. Because at the end of the day, if I do my job well, they're not considering that. They understand the 4 motions of their low back. They understand the 4 motions of their elbow and how to keep it moving well by moving their elbow or their neck or their mid back and changing their posture. They understand the problems so that they don't have to do something that's not indicated. And unfortunately, in the current milieu of American healthcare, I don't have that luxury very often, meaning I want to reverse the problem, return to all normal function, and teach a maintenance and prevention strategy. But most patients just want most of their pain gone and most of their function returned, and they're not willing to go through kind of a longer course of care to get it all right. And like Mark says, at the end of the day, if that patient has their symptoms return in 6 months or has their symptoms return in 2 years, and they don't understand the problem, they're probably going to think to themselves, oh, well, physical therapy helped me 50% or 75%, but physical therapy is too basic. It's not what I need. Obviously, I need something more because this problem came back. And that something more is those things that I mentioned, not just surgery, but other invasive, very new, quite frankly, therapies. And if we were tallying up clinician outcomes, going and looking at 2, 5, 10 years since point of care, that would be on me if the patient finished the course of care with me and had that outcome. Of course, if the patient doesn't finish the course of care for me, that can't be with me, that can't be kind of my responsibility because they haven't absorbed or taken all my recommendations on board. But I'm thinking that down the line. I'm thinking that if I don't teach this person what's going on in a way that they can understand, and they usually need to understand that these tweaks happen and they're preventable and reversible without future medical care if you abide by these principles. If I don't make that clear, I fear that scenario happens a lot. People really just think, oh, neck retraction, it's simple. She seemed like she knew what she was talking about, but no, this neck pain is now going down my arm. And, the surgeon says it's an easy surgery to decompress the nerve, and we'll see what happens. Not to mention, of course, if you have a significant surgery orthopedically, you will not necessarily, but usually need to do some form of rehabilitation afterwards. So it's not necessarily a time saver, which some people think it is, but it's just a lot more risk by being invasive. And of course, if we are looking at kind of the national landscape, we also want to consider cost. But the personal landscape, people are not really considering that because the system is so opaque and they don't understand the cost because of the insurance paradigm that we have in the United States. They're not considering that, oh, my back surgery cost $25,000, but diligent physical therapy for 2 months would have been $2,000 or $3,000 or whatever it may be. So I take it very seriously that I want people to understand how their body is working so they're less vulnerable to claims down the road, which may or may not be true, that their problem is actually much bigger than they thought or bigger than they thought. And because physical therapy wasn't really helpful in the long term and the problem came back, which they usually do if patients fall off the wagon, that they need something more aggressive.